So obviously, Mark has already alluded about how we started. So this is late Terry Hamblin, together with Professor Danny Kotowski, started UK CLL Forum and CLL Support Association is a natural development from that. So, so who we are, basically, if you go to the website, so I just quickly go to that website, and you sorry, you probably can't see. So on our website, you can see most of people who actually had time to provide us pictures and little bios. So you can check us out. So this is who we are. And what do we do? These are very briefly our constitution objectives. So this is the constitution which was created in 2000. So the main thing is education. Not only doctors, nurses, patients, of course, as well. Also, we trying to develop different guidelines and communication. So advancement of education, it was kind of the mainstay of education is our biannual meeting. So we always meet up in March and in October. Obviously, the last two meetings were virtual. I have just decided together with core of execs that we'll have a hybrid meeting. So if you feel safe to attend the meeting in October, you're obviously invited. And during those meetings, we invite new scientists and new doctors to obviously to present their latest work, show some posters. Also, we've got Hamblin and Professor Kotowski prizes to showcase up and coming young scientists. And also we offer travel grants for scientists and hematology trainees. And of course, we're trying to work very closely with CLL Support Association to promote patients' education. As far as guidelines is concerned, so obviously in 2012, there was the guidelines which was published by Professor Ossier. This was a new guidance was published in 2018, led by Professor Anna Shu. And I'm currently working on updating a new guidance because obviously things changed quite a lot, which I will allude in my presentation. We have already finished working on guidance on management of cardiovascular complication in use of Ibrutinib and other Bruton tyrosine kinase inhibitors. So that should be officially published very soon. And of course, during the pandemic, we posted on our website practical guide how to manage the patient. So the most recent, I think version 6 is still there. It's kind of joint link between the 2018 guidance and the new guidance. So this will just shows the clinicians and other healthcare providers what we should do with if the patient needs treatment. And also, as you know, during especially early days of pandemic, where shielding was very difficult to understand. We didn't even know what shielding exactly meant. So we worked together with Mark and other CLL Support Association trustees and Leukemia Care, trying to tease out what means shielding and staying safe during pandemic. So as far as the developing the treatment, and I will sort of elaborate on this a little bit later, we've been involved in NICE appraisal, showing the clinician aspect of the new treatment. So these are the examples what we've been involved in, and I slightly elaborate on that later in my talk. CLL Forum also runs real-world data that was started off with Professor George Follows from Cambridge, who collated the data on Ibrutinib when Ibrutinib was first available back in 2014 as a sort of early access product, and it was very important to understand the side effects, why patient comes off, and how to mitigate those side effects. More recently, during COVID time, we've done COVID survey. It was both COVID for the patients. So I'm sure many of you participate in patient survey, and we have submitted that to IWCLL, which will take place in September. There is a clinician survey as well. Well, as clinicians, we didn't do as well as you did, guys. So we had absolutely amazing response from patients. And we're about to start sort of collecting, sort of similar to what George did with Ibrutinib, with acalabrutinib, because acalabrutinib became available during pandemic as an early access program as well. So just briefly, just to run who does what. So since I took over the UK CLL Forum, I created roles. And I mean, obviously we all, that's all voluntary. And we're doing in our spare time. So so there are doctors, Dr. John Riches and Dr. Ingo Ringhausen, been updating and restructured the whole website. Tobia is leading Launch Twitter. And there is now a rota. Every month somebody else sends the tweets. Dr. Ramsey is looking after Facebook page. Professor Stankovic and John Streffords are highlighting significant scientific papers, so you can find them on our website. And I managed from after our last meeting in March, Professor Frida Stevenson very kindly agreed infrequent review of what's happened in CLL. As I mentioned, I've restructured the whole membership. So what was important to do to increase emphasis on role rather than a time served. So this was done by Dr. Pepper. And that way we managed to invite more scientists. So we've got about 30% of scientists. And also we've increased number of patients who are members of UK CLL Forum. There are also, so Professor Anashu invited specialist nurses as well. So we quite there is quite a varied representation for CLL Forum. And I think the most important, and that was the pandemic, which forced us to actually act on it, is trying to get a representative from Northern Ireland and Scotland. So from Northern Ireland, we've got Dr. Fergal McNichol, and from Scotland, Dr. Alison McCaig from Glasgow. Of course, we always had a Welsh representation, so it was Professor Chris Fagan was almost from the beginning. Now Professor Fagan retired, and we've got Dr. Neil Parry-Jones who represent Wales. As I mentioned, one of the most important part of Forum is to talk to you guys. And hopefully with Mark, we managed to expand our projects further. So one of those collaborative projects, as I mentioned already, is the COVID-19 project. And I would like to do more. And we already had discussions, especially the projects we found very, very difficult to do. For instance, use of immunoglobulins in CLL, trying to get the data from hospital is almost impossible. So this is type of survey we would like to divulge to CLL Support Association, and to see whether we can engage you guys to give us data, because I think this is where there is no evidence for use of immunoglobulins in CLL. But obviously this is a very important aspect. And another spin-off which I've started is we've started podcasts. We only had a first one, so you can find our podcast on the usual podcast on iCloud, on the SoundCloud. So this is an interview. First one was with Peter Hillman, so that was now 2-3 months ago, and I'm intending to carry on. Obviously I can't do it in a regular basis, so it's probably won't have sort of monthly frequency as I would like to. So when you're diagnosed with CLL, I know it's quite a daunting prospect, and just and I'm telling you, well, this is a form of a cancer, and then I'm just letting you go, but you're not alone. So other than having me or another clinician, having a nurse or specialist nurse, as you can see, there are loads of people behind. I mean, obviously, there is a CLL forum there. There is CLL Support Association to support you. And there are a few other organizations, as you can see on this study. And it's throughout the treatment, active monitoring, or support during those two aspects of your journey. So let's talk about therapies. So, I mean, you know, the drug cost is skyrocketing up, and you can see that this is projected increase 11 to 14%, and the sums are just eye-watering. But one thing I saw once presented at American Society of Hematology, this was back in 2019. I was surprised that I found the UK in 50% of new cancer drugs. I mean, we're complaining about our system, we're complaining we've got no access, and then I can see that UK is there. At 10.9% amongst US, Germany, France, Italy, Canada, Spain. And then they showed another slide, 75% of all new drugs, and UK is still there among US and Germany. So I think you know, it's a quite a good place to be in with hematology. So let's just dial back in NHS and how the drugs are available on an NHS. And of course, there is limited amount of resource. And this is an estimation. Obviously, this is old data, 2018, 2019, 19 billion pounds is spent on drugs, which is approximately 15% of all public spending on health. And this is how it works. So bear with me. I know it looks fairly busy, but if you look at the left, these are your common garden drugs. These are your heart medication, blood pressure meds, diabetes meds. So these are vast majority of drugs, low-cost drugs, which are covered and paid by NHS through payment by result. Then in the middle, you've got chemotherapy. So this is an old-fashioned drug which been there through special commissioning. And then on the right, you've got a new drug, the expensive drugs. So obviously all those drugs which cost more than £10,000 per course, all those drugs need to have a license. So basically they need to go through EMA, European Medicines Authority, so to get approval. And then obviously now it would be more MHRA. Then they need to go through NICE. And I will go in details how drugs go through NICE appraisal. Then there is a cancer drug fund, and then hospital has got 3 months to make it available to the patient. But of course, there are some drugs which are unlicensed. So for instance, Ibrutinib, which was available thanks to early access programs, but it was unlicensed at the time. So it still needs to go through quite an important review. And of course, even if you are a private patient, that needs to have some kind of approval. So in UK, we can't just willy-nilly prescribe any drug. At least I will need to have an FDA license or European license to prescribe the drug. So we've got NICE, which is National Institute for Health and Care Excellence, which is something many when we go to, or we used to go to conference, many countries were quite envious of. So this is a body which appraises drug effectiveness and takes detailed negotiation between NHS and pharmaceutical company to agree the prices. So let's go through a brief timeline. So it hasn't been there forever. It was created back in 1999 by Tony Blair, and it was initially called National Institute for Clinical Excellence. Now the name been slightly changed to extend its remit. So it's always also just changing to Health and Social Care Act. And the main aims of NICE are these points here, so I'm not going to read them out. You can obviously look at yourself, but what I would like to, so what is really important, that basically all new drugs will go through NICE. Before 2005, NICE would choose drugs to assess. From 2005, it's statutory to check each new drug, whether NICE will pay for it. So obviously these are the principles from NICE. So it's very important on high quality, good value, best outcomes. So this is really evidence-based medicine at its best. They, you know, there are loads of groups, loads of steps. Yes, it's quite lengthy. It can be quite bureaucratic, but it's trying to tease out which drugs are truly the best ones for our patients. And you may have heard of QALYs and ICER. Obviously NICE evolves how they assess their mechanism of assessment. So, I mean, it probably would be worth to invite someone who works with NICE just to explain sort of from an economic point of view how they're looking. But essentially, the QALYs, so the QALYs are quality adjusted life years. So what it means that on average, how much we gain from taking each drugs, and they compare in quite detail all existing therapies, including supportive therapies, and it not just looking at extra years, but it takes quite a big emphasis on quality of life. And also there is an increment cost effectiveness ratio. So it sounds very complicated, but it is complicated for a reason, because you're trying to cram in loads of variables which is available for those new drugs. And obviously, though that data comes later, so there is scope for reassessment later. So let's look at the numbers. So in 2004, NICE decided to adopt any drug which are with below 20,000 per QALY. There is a scope to extend that up to 30,000. And they consider degree of sort of innovative nature. They look at different, obviously, patient condition, patient population, and other social costs and benefits. And sometimes they look even beyond 30,000, as you can see, for certain group, if there is a benefit. So it's not hard stop at 30. Now, how does that compare to other countries? So you can see here, for instance, in France, there is a QALY between 50 and 300,000. In Ireland, 45,000 euros. In Netherlands, 41. In New Zealand, only 13,000 New Zealand dollars. And in 2008, that ICR threshold was extended to 50,000, and at least extended by minimum, you know, the life needs to be extended by minimum of 3 months. And as you can see, for very rare diseases, what we call it orphan diseases, where frequency is less than 1 in 50,000, that ICR threshold goes even further. So we also, you've probably heard of Cancer Drug Fund. So this is an additional way we could get the drugs. And this is particularly for new expensive drugs which were rejected by NICE. And that's obviously, that is evolving. And obviously, I'm sure you've heard, you know, with the Cancer Drug Fund being use of it is by, especially by York scientists, being questioned validity of Cancer Drug Fund. And certainly there is loads of hematological drugs on a Cancer Drug Fund. And in 2021, there was supposed to be, obviously this is now supposed to be reform of the Cancer Drug Fund, trying to encompass other conditions. If you find this interesting and intriguing, there is a very, very nice summary, which I used to base these slides from kingsfund.org.uk. So if you want to know a little bit more, I would like to, please do refer to this. So when the NICE reviews the application of the new drugs, it comes to us, to UK CLL Forum as a CLL clinicians, and we report what we think about the appraisal and what we think about the drug and the place of this drug in our current way to treat the patient. That request also goes to CLL Support Association, Leukemia Care, and few other bodies. But for instance, Royal College of Pathologists and British Society for Hematology comes to me. So we write a report on behalf of CLL Forum, British Society of Hematology, and Royal College of Pathologists. And there were few appeals. So these are examples of recent appeals. So there was appeal for Ibrutinib, venetoclax rituximab, and venetoclax obinutuzumab, which is the most recent. So you may remember the Ibrutinib hit the headlines back in 2018. So this comment was written by Sean O'Neill, who is one of the patients, and Ibrutinib was denied to him because he relapsed more than 2 years after previous therapy. And the reason why NICE used that landmark of 2 years was because the original trial, which approval was based on, which was called Resonate trial, included into that study patients who relapsed within 2 years of last previous therapy. So the NICE is trying to be very close to the presented data, sometimes too close. So of course, this went to the press. We, as a UK CLL Forum, we have replied, and obviously CLL Support Association, we worked in parallel, and as Mark said, CLL SA has patron Lord Forsyth, who raised the issue in the House of Lords. And that helped expanding use of Ibrutinib. So essentially there is no clause of 2 years. Anyone relapsing after a previous line of treatment, regardless of time it relapsed, can have Ibrutinib. But that's the nuances of evidence-based medicine, because if you use a clinical trial to approve the treatment, and that clinical trial says 2 years, this is where obviously that communication from clinicians and the patient needs to be there, because in real life it's very, what can we do with those patients who clearly need treatment? You can't really go back to less efficient therapy when you've got Ibrutinib there. So other successful appeals was venetoclax rituximab. So venetoclax rituximab came through 2019, January 2019. And it was rejected initially. And the reason it was rejected was because it was very first time those novel therapies were presented as a fixed duration therapy. We've heard John Moore saying here the venetoclax rituximab, and he would have fixed 24 months of therapy. And that was questioned because one of the representatives on the panel said, well, and he was a clinician working with CML, which is chronic myeloid leukemia. As you know, with chronic myeloid leukemia, patients are taking imatinib. And in the past, imatinib been taking, once you start imatinib, take it forever. And of course, we've got Ibrutinib. When you start Ibrutinib, you keep taking Ibrutinib until it works. If it works for 3, 4, 5 years, you continue taking for 3, 4, 5 years. So the panel was saying, well, the clinicians will not stop venetoclax. They will just continue prescribing venetoclax. And of course, we're talking here, it's a very high cost drug. And the whole appeal of this fixed duration therapy is for NHS is the price. Because of course, if you look, Ibrutinib, approximately it's about £50,000 per year. So if you take it for 5-6 years, do your maths, that's a lot of money. If venetoclax is similar drug and you give it only for 2 years, that's obviously for NHS, that's a lot of savings for other patients. So we managed to appeal that to say that no, I mean, the data is for fixed duration therapy, and we will stick with the data because of course, it's quite tempting if somebody does not have negative MRD, we talked about minimal residual disease, it would be tempting to carry on. But the data is that you should stop. And actually, the data is showing that if you don't achieve MRD by 24 months, carrying on for further few months with venetoclax alone is not going to really improve the level of CLL. And the other issue is that currently I'm trying to work with NHS England with BlueTech clarification. So what that means is all the drugs which are on NICE or Cancer Drug Fund, we need to fill in electronic form for these in a form, the website is called BlueTech. So it's fairly easy website, you do it very quickly, and you just basically tick the boxes. Now, the boxes for venetoclax rituximab are the boxes we've got concern with, because at the moment, you can have venetoclax rituximab as long as you had chemoimmunotherapy. And that's obviously a problem. Now we've got loads of patients on acalabrutinib, loads of patients on ibrutinib who were on FLAIR study. Now FLAIR's been added, so all patients who had ibrutinib and relapsed post-ibrutinib can have venetoclax rituximab, but then we've got this gap. What happens with other patients, would be quite a retrograde step from ibrutinib or acalabrutinib to go back to chemoimmunotherapy, so I could give you venetoclax rituximab. So this carries on. The other issue is, what if patients relapse post venetoclax obinutuzumab? So venetoclax obinutuzumab was only approved a couple months ago. Maybe not a couple months, it feels like a couple months ago, it was early this year. And we know that patients who relapse post venetoclax obinutuzumab, they can have retreatment with venetoclax rituximab, but that's still not reflected on that electronic form. So the last problem with venetoclax obinutuzumab. So when venetoclax obinutuzumab went through NICE, we had real issue who is it going to be approved for? Because the CLL 14, the German study, basically used elderly, unfit patients to show that venetoclax obinutuzumab is good for these patients. And of course, at the moment, there is not really much of published data. What about the youngsters, the young patients? Why should we offer them chemoimmunotherapy? And with chemoimmunotherapy, you know, some of those patients respond really well, but some of them pay price later. And especially if they, if currently I've got a young woman who's in her 30s, she's got many decades to develop myeloid problem, acute myeloid leukemia. Yes, it's rare, very rare, but it happens. So it is quite difficult. So what NICE did, so of course there was no data to approve through NICE, so we can treat young patients with venetoclax obinutuzumab on the basis using Cancer Drug Fund, which is fantastic. But the problem comes in Scotland. That opportunity is not there. In Northern Ireland and Wales, the young patient can get venetoclax obinutuzumab first line, but not in Scotland. So this is something which obviously we need to address. So how algorithm of current guideline looks like. I'm not going to go into nitty-gritty of the actual treatment. I'll just kind of tell you overall. So back in 2019, so this is a survey of just over 150 cases. And as you can see, back in 2019, chemoimmunotherapy in frontline was predominant. And as you can see, only small group of patients had Bruton tyrosine kinase inhibition, and these were for patients with TP53 abnormality. And obviously, in green, you've got clinical trials. I'm a big believer in clinical trials, so obviously our clinical trials took quite a big hit during pandemic. But it's very important that if we can treat patients on a clinical trial, that option should be there. Early in 2020, chemoimmunotherapy started shrinking. And because we got acalabrutinib as an early access program, so as you can see, the blue bar has increased. And this year, since Veno been approved early in 2021, this is my practice. There is one time I have given the patient chlorambucil obinutuzumab option, but after sort of talking to the patient, working on her comorbidities, trying to fit her in, she's actually started acalabrutinib. So, so in my practice, I'm not saying I will not give people chemoimmunotherapy. There will be some cases where I do, but it will be exception rather than a rule. And again, in my practice for the relapsed cases, and that really since 2019, I have not prescribed chemoimmunotherapy in relapse. And I truly believe chemoimmunotherapy in relapse cases, there is no place. And that's since beginning of 2019, since venetoclax rituximab has been approved. So in summary, there are quite a good few points being a patient in the UK, and I think it's amazing with CLL Support Association, with Leukemia Care as well. You've got a lot of support. There is a lot of treatment available, different options, and we at the moment we truly spoiled for choice. It is very evidence-based, so whatever goes through NICE, we feel reassured in it has been properly scrutinized and based on clinical trial. And I can't, emphasize how important your voice is. And it's great to work with you as partners rather than me telling you what to do. I always ask the patient for their choice. I'm there to advise, not there to make a decision. And I can say that's true for the whole lot of UK. And when I attended conferences, I think that's not really true outside of UK. But there are bad points, of course. But with that careful evidence-based process, bureaucracy is huge and it's slow. And as I mentioned, there are some postcode discrepancies, like mentioning Scotland not going very far. Clinical trials currently are very pharma-driven. It's just the way it evolved. Professor Danny Kotowski was running CLL4 study, if you may remember, back in late 90s. And that was MRC, Medical Research Council sponsored study. And it was the questions were designed by clinicians, scientists. So those are sometimes very difficult questions, and that's gone. And I can't see that happening. So, but pharma is getting more open how to design the studies, and they're obviously involving us more. So, of course, Resonate, the one of the first studies when Ibrutinib was approved was compared to ofatumumab. Ofatumumab was not valid comparator, but I've got, the Ibrutinib is such a good drug that it didn't need it. Good comparator, but nevertheless, to do a good clinical trial, one needs very good comparator. And now all the studies which are running, looking at Murano, German studies, acalabrutinib. So Elevate-TN, which led to approval of acalabrutinib, had very good comparators. So comparator was chlorambucil or obinutuzumab, and the Ascend, which was approval of acalabrutinib in second line, had comparator, which was bendamustine rituximab and idelalisib-rituximab. So that was first comparing non-chemotherapy to non-chemotherapy, which was a very, very brave design, and that was started back in 2017. So that's moving on. And as a CLL, there are plenty of options, but then there are CLL-like diseases, like for instance, splenic marginal zone lymphoma, where there are not that many options, and there are no clinical trials because there is not enough numbers. So it is can be quite frustrating for me as a clinician to offer fantastic treatment for a group of patients and then not such a great treatment for other group of patients. But yes, this is what we need to face at the moment. So I rattled on, so it's 2 o'clock, time for questions.